As Ted said, I'm going to be talking on this topic of biological and demographic causes of high HIV prevalence among MSM. I'll sort of come back to the end about why I think this particular topic matters so much in terms of the current state of dialogue and understanding about HIV prevention among men who have sex with men. So the initial requisite slide, this one's actually somewhat out of date. I had hoped to update it last night, but the wireless was down at Ted's house. So this is out of date, but the information in it hasn't really changed much, or at least the take-home message hasn't changed much, which is that 25 years into the HIV epidemic in the United States, men who have sex with men continue to be have rates of HIV prevalence and HIV incidence that are higher than any other risk group in the country. Comprise at least 50%, if not more, of the new cases of HIV. So this has been a consistent message for a long time in the U.S. So there's a sort of endless message about why these large persistent differentials exist. And I think if you asked the average person on the street, if you asked my mom why this is, if you asked Mrs. Goodrow why this is the case, after turning beet red, she'd probably have imagined that it's because men who have sex with men just have large numbers of sex partners relative to heterosexuals. That probably has to be the whole story. So to what degree do behavioral differences explain this story? Perhaps some. The computer seems to be frozen. Oh, there it is. Okay. Perhaps some. But what often happens in the conversation out there is that behavioral differences, I think, or sort of individual level behavioral differences, don't necessarily explain as much of this differential as the person on the street thinks it does. And we often see in the world of HIV prevention, then the alternative explanation tends to focus on the sort of bigger structural issues of stigma, which leads to depression, which changes men's rates of health-seeking behavior, and sort of all these, bigger, and homophobia, and these kind of issues that are much more sort of ultimate, and also, are certainly important things to look at. What I'm going to focus on today is kind of putting those on hold for a moment, not to say they're not important, not to say they're not pieces of the story, but to think about two other pieces of the puzzle that one of which has been well known for a while, one of which is a little bit more subtle, but both of which I think don't get talked about enough or don't get included enough in this story about why about this differential. The first is the simple, straightforward issue that HIV infectiousness is much higher for anal sex than it is for vaginal sex, a simple biological difference. And the second one, which is more subtle, is the demographic difference, basic demographic difference, which is that heterosexuals are a two-sex population and gay men are a one-sex population. What in the world does that have to do with HIV differentials? Why does that matter? And it also comes down to an issue of probability of transmission. HIV is more easily transmitted from the insertive partner to a receptive partner for both heterosexual, for penile vaginal sex as well as penile anal sex. All right? The difference probably is bigger for anal sex. The differential is now being debated again in the literature. It's not exactly clear what the number is, but I think conventional wisdom is still that it's present and probably less of a difference than it is for anal sex, but still present. Again, what does that matter? Well, if you think about the sort of population level effects of that, for a two-sex population, basically heterosexuals engaging in penile vaginal intercourse, basic biological difference here, the males are always the insertive partners in that kind of relationship. The females are always the receptive partners. For HIV to transmit through a population along a chain of transmission in that, basically the virus, from the point of view of the virus, it needs to go from male to female, which is relatively easy for it, and it has to, sort of the only option in a purely heterosexual population is then to go from female to male. And that's a bottleneck from the point of view of the virus, right? That's less transmissible. And then again, male to female. So any of you who've taken chemistry and learned the sort of mathematics of that, when you have a process that has to go through a bottleneck, that tends to slow it down. Whereas for a one-sex population, this sort of bottleneck can be bypassed at the sort of level of chains of transmission, where a male can transmit relatively easily to another male through where this male is the receptive partner, and then with another partner, this male is capable of then being the insertive partner and transmitting easily again. So the virus doesn't have to go through these same bottlenecks, it sort of can transmit easily through these chains. So that's the more subtle of the two pieces, something that doesn't get thought about very much. However, so that's possible for MSM, but isn't universal. This issue of role versatility, a man's playing both insertive and receptive role over time with different partners, is hardly universal among MSM. Its prevalence certainly varies widely cross-culturally. In Latin America, where I've done some work, it's less common. It's more common for men to sort of have role segregation and consistently play one role or the other over time, and so you sort of have more of a similarity to this kind of heterosexual transmission. So this, I don't mean to say that role versatility is universal among MSM, and therefore the virus, there's this sort of infection superhighways, but it's certainly present at different levels, and we'll come back to looking at that. Part of why this doesn't get thought about very much, I think, in traditional epidemiology is that in this situation, role versatility is not doesn't have to be an individual risk factor. So if you look at this case, role versatility, this man is insertive, this man is versatile, this man's receptive, right? Who is put at added risk in this situation relative to a scenario where you have role segregation? It's this man, right? This is not necessarily a role versatile man. In this simple example, this is the man who's versatile. It's the receptive partner of a versatile man who is put at added risk, right? And then he may himself then turn around and be versatile and put another partner at risk and so on. But you don't necessarily have to see, an individual level risk factor where you go out and you do a study and you ask men whether they've been insertive, receptive, or both, and look at HIV prevalence. You're not necessarily, if you do that kind of study, you're not necessarily going to see versatile men showing higher rates of HIV prevalence relative to, say, men who are exclusively receptive. They probably won't. But even without being able to detect it at the individual level, you still have this sort of population level risk factor where the presence of versatility, just the overall ability for men to be versatile puts the population at a higher risk than it does for a population with role segregation. So that just makes it hard or potentially impossible to measure its impact directly. And any of you who've ever tried to design a study to get funding from NIH to look for the impact of something where you can't detect it at the individual level, and therefore you have to do some sort of community levelized trial or do something, you know that if it's hard to study at the individual level, it's hard to get funded and it's hard to pursue. So I think that's part of the explanation for why we haven't seen much thought about this. It's also hard, so it's hard to study, and it's also hard to get a sense, okay, I can sort of logically explain to you in 3 minutes why it is that one might imagine role versatility would be a population level risk factor for HIV transmission, and therefore why it might have something to do with explaining the disparity between MSM and heterosexuals. But it's not necessarily easy to have an intuitive sense of how important should that be. Is that, yeah, I can understand that phenomenon exists and why it would matter, but does it really, when all is said and done, does it explain a lot or little? It's very hard to have an intuitive sense of that, which is why we need to use the tool that I specialize in, which is epidemic modeling, mathematical modeling of epidemics, which is one way to sort of get purchase on this issue and try to get a better sense of, okay, if this is going on, how big of an impact should it be, and is it something worth thinking about? How many of you have ever taken or studied mathematical modeling for epidemics in any way? Just 2. Okay, 3. Okay, so that's good, because I have these requisite slides that try to explain epidemic modeling to novices at a more of a philosophical rather than a methodological level in a few minutes. And so I always put them in. Sometimes I skip them, but it sounds like it's worth going through here. So just to give you, for the 95% of you without modeling experience, just to give you a very quick sense of what modeling is and sort of how it fits in with the rest of epidemiology. If you think about the scientific method here and what we allegedly are doing, of course we're in epidemiology, which is very difficult to do experiments all of the time in. So this is challenged in a number of ways. It's also, I'm in an anthropology department, so when I work a lot with cultural anthropologists, so I always put up the ways in which I'm aware that science has its own issues. But this is the piece that I'm going to focus on here, which is, okay, somewhere in the scientific method, you're starting off with a theory about what you think is going on, and you're supposed to make a prediction as step one. Often designing an experiment to do it is hard enough, but we sort of take it for granted that if I have a theory about what's going on, I can immediately make a prediction about what it is, about what I would expect to see if that theory is true. So say, for instance, in this case, my theory is that role versatility explains this differential. Therefore I should be able to make a prediction. But the problem I mentioned earlier, that it doesn't create this individual level risk factor, makes it hard to have any sort of immediately testable prediction from here. So imagine I have these sort of set of hypotheses generally. I think A, B, C, and D are true. And the sort of typical philosophy of science says, well, I should be able to deduce from that, okay, if A, B, C, and D are true, then I should predict that Z is also true. And then I can test to see if Z is true, and that helps me figure out if my antecedents are true. What often happens in the world of infectious disease epidemiology is that not only is it hard to design an experiment to test if Z is true, it's also hard to figure out what Z is supposed to be from your antecedents, right? And that's exactly what's true in this case, and it is true a lot of the time in infectious diseases, because infectious diseases are classic examples of complex systems that have feedback in them, that are transmitted on highly structured, non-random contacts with thresholds and all these sort of complicated complex systems features, right? This is the sort of classic example. Everyone has to put up a figure of a complex network to show how complicated this world is. And this is sort of, this set of slides gives you an example of how it matters, how the consequences of getting the sort of details of these complex systems right can be. So just as an example, imagine a population in which everyone has either 1, 2, or 3 sexual partners, okay? And here's the distribution in the population. About 40% of people have 1 sexual partner, about 45% have 1 sexual partner, 45 have 2 sexual partners, and about 10 have 3. The mean number of sexual partners in this population is 1.68, right? If you assume that beyond this, people sort of choose their partners randomly, and you use modeling tools, and you simulate what this population would look like as a network, this is basically what it looks like. It looks like there's a bunch of other sort of isolated monogamous couples, and then this is sort of the heart of the system. This is where most of the action is. If you imagine a slightly more active population in which now a few more people have 3 sex partners, then the mean number of sex partners in this population has gone up by 6/100ths of a partner. This is what the network now looks like. If you imagine a scenario in which it's gone up 6/100ths of a partner more, and you simulate an epidemic from that, this is what the network looks like. And then if you imagine it goes up 6/100ths of a partner more to 1.86, and you simulate that, this is what it looks like, okay? If you went out and do you have you have some hypothesis about your population, and you imagine what you expect disease, HIV transmission to look like in that population, and that's a population that has 1.68 partners on average, and you have another one that has this. Would you, are you necessarily going to be able to predict, is your model going to be able to predict that, the sort of difference between this and this? No, because again, this is just a point about how these are complex systems, and complex systems have threshold effects in them that are very nonlinear, and all of the issues that arise from that. So, I think most people would be very hard-pressed to be able to use any kind of formal logic to predict that a population with this distribution of networks would have this distribution of sexual partners would very likely have a large STD epidemic, and this one would have a very small one. Right? And so the only way you can sort of see this is using these kind of mathematical modeling tools, simulating populations and simulating disease on them in the computer and testing it that way. So that's just my little hand-wavy peon to modeling to explain it in 5 minutes. I don't explain all the methods of it, but just to give you a flavor of some of the reasons why it can provide insight that it's very hard to get from other forms of real data, yeah. Modeling, however, is not sort of the opposite of real data. Good modeling uses real data as part of its starting point. So our aim in this paper, coming back to the original questions, was essentially this sort of modeling thought experiment, which is to think about this differential between MSM and heterosexuals, and to frame it as a thought experiment for the moment and say, how large a difference in epidemics might we see between an MSM population and a heterosexual population if they were identical in their behavioral characteristics, the numbers of partners people have and the way those partnerships are put together, but they differ only in these two basic characteristics that I mentioned before. That there's it's sort of including the transmissibility difference between vaginal and anal sex, and considering the sort of one-sex, two-sex issue and the fact that MSM can be versatile. So I'm not saying this is true, that MSM and heterosexuals are identical in their behavioral characteristics, and a lesson for you when you're publishing science is that the popular press that picked up on this paper totally misunderstood that point, and the headline was, researchers show that gay men and heterosexuals have exactly the same sexual behavior, which of course we said 5 times in the paper. We are not saying that gay men and heterosexuals do have exactly the same sexual behavior, but this is a thought experiment. But of course that was what some of the reports said. And so we're going to use this mathematical model, and we're going to parameterize it with these 2 data sets. Now I just said I'm not saying that they're identical in sexual behavior, but I am going to make a claim that they're a lot less different in sexual behavior than the person on the street, than my mom probably thinks they are, at least in terms of what matters from the point of view of HIV, which is unprotected anal or vaginal sex partners. We don't have, or at least I was unable to find data from 2 different sources, one of MSM and one of heterosexuals, that asked the same questions in the same way that really allowed us to be able to compare and look at this. But this was sort of the best we were able to do at the time, which was to go to the NHSLS, the National Health and Social Life Survey, which was a sort of nationwide stratified sample of the US population that asked all about their sexual health and sexual history. This was Ed Lauman's study from the University of Chicago. And to ask them about the number of sex partners they've had in the last 12 months, and this is what the distribution looks like. The vast majority, you can sort of piece together all the different tables, and you can find out that the vast majority of the sexual partners they're reporting here are vaginal sex partners, and condom use was low, right? From the Urban Men's Health Study, which was sort of one of the early sexual health and sexual behavior surveys of MSM done in 4 US cities, this is the distribution of any sex partners for them. So you can certainly see at this level a huge difference, right? A much higher number of MSM are reporting having had sex with 2 or more partners in the last 12 months than is the population as a whole of the US, right? The median here is 1. The median here is 3. and the mean is pretty high. However, again, that's all sexual contact, which includes oral sex, et cetera, lots of different things. If you only look at anal sex partners, that distribution goes down considerably. And if you only look at unprotected anal sex partners, which again is what we mostly care about as in the world of HIV, you see precisely the same number of men in the 2+ category. You see, you see a far, far higher number of men who are having 0 partners than you see over here, right? These are, presumably many of these either are or think they're in mutually monogamous relationships. Is presumably what's going on here. Over here you see, the median for MSM, well over about 2/3 of the population are having no unprotected sex at all, no unprotected anal sex. The mean number of partners is 1.3, right? So from the point of view of the activity that matters for HIV spread, this is pretty low, I think. This is not this sort of off the charts impression that most people have, I think. So again, not saying heterosexuals and MSM are exactly the same. I don't have information about how long this tail is. They don't report what the mean is. We can't say that. I don't have information about how far out this tail goes, but I do know the mean is 1.3, which is not very high. It can't go out super far. So just to give a little sense about the model without going deeply into the sort of methods of mathematical modeling, which are hard to convey quickly. For those who do know, it's a deterministic compartmental model. Much of the work that I do is in agent-based and network modeling, but this paper is not, for various reasons. And basically, we're modeling men who come into a population seronegative and then seroconvert and leave the population. We're going to consider men having 3 different levels of unprotected anal intercourse per year, which is coming from this distribution here, with an overall mean of 1.3. And then we're going to divide the population up by role. So, when we're modeling the heterosexual population, everyone's either male or female. When we're modeling the MSM population, men can be versatile, or there are some men in the population who will always be insertive. There are some who will always be receptive in the simulation. And the probability, you sort of put all these pieces together using these mathematical modeling tools. You derive equations for the probability someone in that's seronegative is going to become seropositive as a function of all these things. How many partners they're having based on their activity level, who those partners are based on the mixing patterns, whether or not those partners are seropositive, and then some model for the probability of transmission given serodiscordant contact. So this very simple model that only basically looks at 3 characteristics of people: what their activity level is, what their role is, and whether or not they're positive or not, leads to this set of equations, which is big and messy. So this is a lesson for those who are interested in mathematical modeling, that it gets complicated quickly. And those of you who are reading mathematical modeling papers and thinking, why didn't they include this, and this in the paper? This is why, because just a simple paper leads to this set of equations that has to be solved. In terms of the numbers we put into the base model, we have sort of, we use that distribution in the slide I showed before of the fraction of the population in each of these categories in each year at any given time. And then again, none low is people who have 1 partner per year, high is people who have more than 1. And again, the numbers of partners they're having per year works out so that the mean of this distribution is 1.3. This is heterosexuals are 50-50. MSM, those of you who've worked with MSM data probably won't be surprised that more men report being exclusively tops than report being exclusively bottoms, which is a bit of a mathematical impossibility, but we did the best we could with that. And then for assortative mixing, what you see in these data sets is that, again, this is sort of capturing the tendency towards mutual monogamy. So someone who only has 1 partner, their partner is more likely than chance to also have only 1 partner, right? So this is capturing that tendency towards mutual monogamy that's in the data. Of course, the data on this are always suspect because not everybody knows whether their partners actually are being mutually monogamous, but at least we're going to go with what the data say for now, at least. We took the probability of transmission per act from Varghesi's meta-analysis of all the previous studies. Now we have much better data than we did at the time about acute infection, and I'll come back to that at the end. But these are the numbers we took. Acts per partnership came from the Urban Men's Health Study based on the different kinds of partnerships. These numbers we essentially made up, and voila. Okay, so simulation one of the population was let's simulate MSM using their observed behavior and their observed versatility rate. About, what was it? About 50% of men reported being versatile, and 50% of men reported being role segregated over the course of a year. So we simulate that population, and lo and behold, we get an epidemic that's in the low teens in terms of prevalence. Right? That's where it stabilizes, which thankfully is a very realistic epidemic. So that's always very reassuring when you go in through all this trouble, you build this model, you know you're leaving some pieces of reality out, but your results, your first model still comes out with something realistic. Some of you may be saying, well, that's not realistic because of this time scale here, right? That's not how the epidemic actually played out. It didn't take 75 years to get up there. And we're well aware of that. The reason it doesn't take 75 years to get up there is that the behaviors that MSM are reporting in the 90s and in the 2010s, the 2000s, are not the same behaviors that were taking place in the 1970s, right? So things were different in the 1970s. This was able to go up much faster, behavior change, right? But we could go through all the hassle of modeling that entire process and how behavior changed. We don't necessarily have good data to do that. That's an entire huge enterprise all in itself that Ted White is actually applying for funding to look at, those sort of early years and how things played out. Instead, what we do is basically say, well, we're interested in sort of where this equilibrates. We're not as interested in interpreting the time scale perfectly. Okay, so that's sort of where our model says MSM, who are engaging in the behaviors that were happening in the 90s and are doing so who are having anal sex at the rates observed in the 90s and are engaging in versatility at the rates that we see. That's sort of what's happening. So my first question, one of my first 2 points at the beginning was how much does versatility matter? It's hard to get a sense of what the population level impact of that should be. So let's do a thought experiment number one, which is what if all men were versatile? Instead of only 50% of MSM in the US saying they're versatile, all men were versatile. They're having the same numbers of partners, everything else is the same. It's just that whenever they come together, it's a coin flip as to who's insertive and who's receptive. And this is what the model says prevalence would increase to, from 13% or so up to 19%, right? So again, no one's having any more sex than they were before. Just this is the impact of that, ability for MSM to be versatile. And if no men were versatile, if they all, came stamped as heterosexuals do with, insertive or receptive, from the point of view of the behavior that transmits the virus, in fact, the epidemic would be considerably smaller. It would equilibrate down at around 9%, right? So just from that fact alone, men being able to, men being able to be versatile and men being able to be versatile at their observed levels at the sort of existing partnership network, the degree to which they are versatile allows the epidemic to vary between 9% and 19%, and the sort of observed epidemic, a full third of it, can sort of be attributed to in this counterfactual way to the existence, to this sort of this ability for MSM to be versatile and for heterosexuals not to. So you can imagine this simulation here is MSM with no versatility, with anal transmissibility. This could also represent heterosexuals if we were on some other planet and heterosexuals always never had vaginal sex, they only had anal sex. Right, so if heterosexuals did that, this is sort of where they would be, because they're not capable. The versatility is not there, but they are, this would be what would happen if they had anal sex. If, however, you simulate the same sexual network behavior, but with heterosexual vaginal transmissibility probabilities, anyone want to guess what happens? there's no epidemic at all, okay? So if heterosexuals, again, and all the behavioral data are coming from the MSM report. So basically what this is saying is that if heterosexuals behaved exactly like gay men seem to in the United States in terms of the numbers of sex partners, the numbers of unprotected sex partners they have, but because of the probability of vaginal transmission being lower, because they can't be versatile, they would be below the epidemic threshold, HIV would die out. Another way to think about that is in order to get heterosexuals to have an epidemic the size of that MSM do, they would need to have 2.7 times as many partners as MSM do. So they'd have to have a lot of partners just to get an epidemic the size that MSM seemed to. In order to have the same HIV prevalence that MSM did during the sort of initial course of the epidemic, it takes longer for it to take off, then they would need to have 4.8 times as many partners on average as MSM do. Holding all else equal, now let's sort of go the opposite direction. Where's the point below which the epidemic dies out? Okay, those of you very few of you have studied epidemic modeling, but I encourage you to do so. And when you do, one of the first things you'll learn about is this concept of reproductive thresholds and feedback, and how below a certain point an epidemic is unsustainable in a population and it dies out, the sort of herd immunity effect and all of that. We saw the heterosexual epidemic dying out even if they engaged in behavior similar to MSM. Where's the point at which it dies out in each population? If you hold all else equal, the sort of distribution of the population in each category, but you just change the mean numbers of partners that people are having. In order for the HIV epidemic to die out, essentially, in the population, to become unsustainable without sort of repeated reintroductions, without overlap with, without IDU, with injection drug use, with just this sort of sexual behavior transmission in isolation, in order to make that self-sustaining, heterosexuals, can be anywhere below having basically three unprotected sex partners per year on average in the population, and they're going to have an epidemic that's really not sustaining that's not becoming a full-fledged generalized epidemic. MSM, on the other hand, need to be below 1.06. Right? And I would say this is sort of above most populations you're going to see in a lot of places. This is quite low, right? So 1.06 is just a little bit above 1, right? And obviously is a much harder thing to obtain at a population level than this. Any of you who are wondering at the moment, what is this? Is he ever going to talk about heterosexual transmission of HIV in sub-Saharan Africa and why that? I will. If you're holding that in the back of your mind, I'll come back to it. But in the US, holding everything else in the model equally, heterosexuals, it's a lot easier to eliminate a self-sustaining generalized epidemic among heterosexuals in the US than it is among MSM. Yeah, right. Okay, we started 10 minutes late, so. This is the part I think is very important. Yeah, we're good? 10? Okay. This is the part I think that is very important of a message to get out to the population as a whole, which is that MSM are much more susceptible in this model, I should say. And again, it's a model, to the high-risk behavior of a small subset of the population. So the proportion of the population that's having more than one partner per year is only 20% or so, right? If you take that rate, again, in this population, the average number of partners is 1.3. If you take the rate of that high activity class, and high is not necessarily all that high, and you triple it. So suddenly, for whatever reason, we stop doing prevention, we stop getting the message out there. Just this small set of people start having higher numbers of unprotected sex partners, and you sort of triple the numbers of partners they're having. Prevalence for HIV prevalence for MSM, for heterosexuals goes up 7-fold. For MSM, it goes up 28-fold. If you only look at the low activity people, so you raise what's going on with the 20% of the population that's engaging and has multiple partners, what happens to the people who aren't having multiple partners? And remember that I put in that mixing by activity level. So the vast majority of these people's partnerships are with other low activity people, but they have some with high activity people. If you just look at the people who are, basically once a year, they, have a, whatever, they get drunk, they go out and, they kind of make a mistake or whatever. Prevalence at year 20 for heterosexuals is 1 in 1,000. For MSM is 26%, right? So, right, so we'll come back to this, but I think this tells a lot about, we'll come back to this. And to sort of, I pull those numbers from this chart. This basically says if this is the level of partnering of the high activity class relative to what we observe in the data. So this is the observed data, and this is HIV prevalence. And this is, I just pulled out if we increased it up to threefold, right? If we increased it to threefold, heterosexual, this is prevalence in the low activity class. Heterosexuals still don't have much of an epidemic. The general population is not still really at risk, whereas, right, heterosexuals don't become that much at risk until really you have to get to levels that are really enormous. For MSM, this is where we're at, according to the data. We don't have to be very high above where we're at for the activity of the high activity men to reach the point where suddenly everyone is just put back again at enormous risk, right? So this is an argument about the interconnectedness of populations and the importance to the population as a whole of prevention among subsets of the population. So some of the implications are that basic and frankly unchangeable demographic and biological factors can play major roles in increasing the susceptibility of MSM in MSM populations to HIV. Partly this is a very pessimistic message. One piece of it that I like to focus on is that the public health community and the general public, and my mother, should not assume that what I started off with, that persistent differences in MSM and heterosexuals in terms of HIV and other STDs, the numbers aren't exactly the same, but other STDs you see similar issues, are due only or even primarily to differences in individual behavior. And it came out too small. This is the Wikipedia page for LGBT stereotypes. And I pull this out because there's an entire section on the stereotypes of gay men as being extremely promiscuous, having large numbers of unprotected anal sex partners, and all of that. And then they cite this paper as counter evidence for that. Again, they kind of get the argument wrong because we didn't say that they don't. But anyway, they are doing this. And so I'm happy to see, I was much happier to see this paper being cited here than elsewhere in the literature, because this is where it actually, I think, matters. This is a message I want to see get out. It also means that I get to use my favorite joke, which is that now I can honestly say that if you look up LGBT stereotypes in the encyclopedia, you'll find me. Sorry, I love that joke. I can tell that joke all day long. Why does this matter? Well, it matters, I think, this is something Ted and I have talked a lot about and something that came up in the podcast today. I think what happens is public health, there's this sort of ongoing battle is maybe too strong. Maybe battle isn't too strong a word, but there's this ongoing tension between public health discourse, public health working on HIV prevention among gay men in the US, many of whom are gay men themselves, not all, many of whom are, and other segments of the gay male community, the men's health movement and that sort of thing, where there's a sort of fear that anytime the public health community focuses on it and brings to light these persistent disparities and the fact that something needs to be done about them, and we have to come up with novel ways to do that, there's kind of a discussion that comes out that by simply pointing them out and acknowledging their existence, we're sort of increasing the stigma on gay men, because there's sort of the implicit assumption that, well, that persistent difference can only, by pointing it out, we're sort of saying it's because gay men are all promiscuous, and we're sort of we're fostering those stereotypes ourselves, even as we're trying to engage in HIV prevention among this population. So there's this kind of backlash that comes. And I think, and many wonderful, true points are raised, as I started out with at the beginning, about how we also need to be thinking about homophobia and stigma and all these sort of broad structural issues, all of which matter as well. They absolutely do. But I think part of what gets lost in there is this piece, and I guess my main goal here is to have this message somehow help bridge that gap and make people realize that the persistent differentials, just pointing them out and discussing them and really making it aware that they're there, does not have to mean that we are, pointing fingers and saying it's because gay men are all promiscuous and we have to change that. That there's middle ground that hopefully can be productive. The pessimistic piece of it is that MSM will remain relatively vulnerable to HIV and STD epidemics even when you shift behavior, right? As we've seen. Which means, there's no magic bullet that comes out of this. In fact, quite the opposite. More broadly, the more broad issue is that there are factors other than individual level unsafe partners that can predispose or protect different populations from STD epidemics. I think another area that I don't have time to talk with today is work on racial disparities in HIV among MSM in the US, where you see black MSM reporting the same exact levels, sometimes even lower levels of unprotected sex, numbers of partners than do white MSM, and yet have much higher rates of HIV. I think there's another sort of network piece going on there. I don't have time to get into it. What about Africa? Right, a large generalized heterosexual epidemic. There's a couple things going on that make HIV among heterosexual transmission of HIV in Africa different than in the US. One is higher rates of infectivity for a variety of reasons. One is lower circumcision rates. One are co-infections with we've seen work on malaria and the syndemic effects of how the sort of activation of the immune system in an environment with large numbers of circulating infectious diseases causes the immune system to be more activated, which means more T cells, so on. So there are issues about higher infectivity in Africa. There's also other structural patterns that were not included in my model at all. And this is an entire other piece of modeling work in terms of the existence of relational concurrency in sub-Saharan Africa versus in the US in heterosexuals. And if you want to hear more about this, because I'm out of time, Martina Moore, any paper by Martina Morris in the last 15 years has been probably been on this topic. This is an entire separate literature that seeks to explain the differentials in HIV between sub-Saharan Africa and the rest of the world for heterosexuals, not in terms of numbers of partners, because lifetime numbers of partners are very similar, but in terms of network patterns larger than just numbers of partners. So there's lots of limitations, which you can read really quickly. And let me just say very quickly, for the future, many of those limitations have to do with things that were left out of the model. And that was because that was a sort of fairly quick and dirty model to try to get that piece out there. But I'm now involved in a much more elaborate project. I like to call it the mother of all MSM HIV models. It's just, it keeps growing, which is what Ted mentioned at the beginning, which basically, the short piece of this is that it basically includes it includes a lot more detail. So if your critiques of your model are you didn't include A, B, C, and D, get back to me in 3 years, because we will have included all of those. And that just says a lot. And then thanks to lots of people, including Ted, for bringing me here, and for lots of fruitful discussions over the years about HIV prevention among gay men.